flexes on softer material like dentin, right? It reduces sensitivity. So research has told us that the preparation has to be on another. It should not flex. The ceramic should remain stable. Now we have a lot of materials available today. Feldspathic, now fluoroapatite, then different types of glass materials, because they are based silica based. Silica based has the same optical properties like glass. So the most preferred material today is IPS Empress. Got some materials both as ingots as well as cat glass. Right? We have these lost wax techniques, lost wax technique introduced by William Started. Even today, for simplicity, one of the most sought after techniques can be easily mastered by anybody. It follows the usual laws of plastics. Even in the material the company introduced has blocks, blanks, right? These are multicolor and the strength is around 360 meters today. The newer companies like Cerat, which has introduced the same IPS from their
portable fan for sir at least one space.
Portable fan. In the fan for what?
Switched off.
Hey, now the mic is working. Mic is working. Collar mic is working. And the electrician again. Now, the collar mic. So we'll.
Color what is that? Yeah, it's the color.
Mic.
Am I clear? Am I clear? So as persons are ready, around the
இல்லை அது ஆன் பண்ணு.
బ్యాటరీ పొద్దు లింక్ కూడా చూస్తున్నారులే புது பேட்டரி இங்கே லிங்கிட் ஆ
Okay, without this I use that. Mask. Just one missing.
Yes, sir, both. So two anteriors.
Two anteriors.
Stop. Cable.
Hello. Angulation of 45 degrees. I prefer a medium. Shallow diamond. So the water flow has to be between 25 to 40 mm, ensuring that the clogging is removed efficiently by the water flow.
Okay. Please share the link with everyone. Sharat, here, zoom here, Sharat. Is it okay now? ಚೆಕ್ பண்ணிட்டா ರಿಲೇ ಆಗುತ್ತಾ ಇದೆ
Labial reduction is over.
No, Mike.
Labial reduction is over. Labial reduction is over. Now I am going to do incisal overlap. Hello.
Sharat. Sharon. So, okay. Can you talk to the chapati fellow? Sahul sir is busy. Can you convey the message through me?
Finishing, just refining.
Last number is 003. In Google, his number is there. We send samosa. He knows the time. You just ask what sir Sahul sir is busy. What do you want to convey to him?
Even I
Did you speak? Oh, okay. Motor. How to switch on the motor? Yellow color.
மேம் கனெக்ட் பண்ணிங்களா ஸ்விட்ச் ஆன் ஓகே போட்டுட்டு சொல்லுங்கள் ஸ்விட்ச் ஆன் ஓகே
No. Display.
Green color finishing head.
Just check if it is red or not. Just check now. Check if it is relayed. YouTube, check. But it is going on right. It's going on right. So obviously. தான் அந்த ஒயர் அங்கேருந்து வருது.
இது அந்த பக்கம்
புரியுது. ஆமாம்.
சொல்லுங்க.
Final year.
இன்னைக்கு போர்ட் மாற்றினதுக்கப்புறம் போயிடுச்சு.
So when you see, come behind the patient, hold the mouth mirror. Keep it at the occlusal view, right? Then you will have overall view of maximum enamel as much as possible, ensuring that the biomimetics are followed. Okay? You have to remove 50%. At the same time, you have to have 40% is bare minimum. And ask yesterday for now if I take an X-ray, you will know how much preparation I have done. Now to be 100% sure, you can etch and I'll show you the frosted appearance of enamel. But at the same time, there is enough enamel for a durable bond, a predictable bond. That is very, very important, right? I will sit and discuss all that once we. With 40 degrees only you will be able to do that. The book says you have to hold the diamond at an angulation of 45 degrees, then only you can start creating the position. Otherwise, you cannot have it. right and overcheck. Depending upon that, you decide yourself. There are sometimes where you will be required to take parallel down. There are some situations if there is discoloration all over and it has to be extended, discoloration has to be masked, then the operation has to be beyond that. Okay.
ஆமாம் 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 லைட் போட்டது அப்புறம் தான் வந்து
Next time is second year.
There should not be any circuits.
money cable.
Come.
He came.
Sir,
He's come now.
he came and he again went down. He said, I'll find something and come. Wire is not. Yesterday it was coming. After changing the port here, it went off.
If you want, I can reduce little more. It's not an issue. This is overload. Though in the studio textbook they describe 3 preparations. 2 preparations we hardly do. Very small percentage. Right? You always go for an initial overload for the better aesthetics. This is an now you take a camera and take this photograph. Then it will look nice. Silica-based ceramics. Even that's okay. It's perfect and these two make up this material. Discolor coat, you have to bleach. If you are unable to get that color of the other central lenses, here zirconia will go. Not a glass lithium density. I don't recommend. It may look good for first 1 or 2 years. The patient will come and trouble you so much that he is suffering with continuous sensitivity whenever he is not good, he will tell you, these are his complaints. I am not able to have a cup of tea, coffee. I am not enjoying my drink. Direct composites still it does better. Right? It's safe. You will not burn your fingers. Right? You would have collected hefty salt. Patient is not going to keep quiet. Keep that in mind. They are lucrative if done correctly. Right.
So where to start the applications?
That's one. Now, different clinicians will have different approach. I felt this as an easy, simple, and very quickly it will start. Now, when you want to create a finish line, you have to keep the diamond at an angulation of 30 to 45 degrees. Then only it creates that finish line. So once that finish line is created, you know for sure that you will not go beyond that. You are safe. Yeah? And already a finish line is created, you will continue with that.
It's like under cut, but it's okay because we're going to place the radial linkage and take it off. We can't do the same thing for a crown.
Finish line thickness. Ideal finish line.
It's very difficult to predict. It depends upon the amount of tooth growth. It varies from case to case, tooth to tooth. Anyway, today we will see one more. We will tell you how to go about doing in that particular case.
Ever?
Finish line, finish line.
Finish line I create so that I am safe. I don't.
Which bar for finish line?
Now,
I mean, right at that.
Srimati, you can just show them.
Yeah. Down.
That is diamond. Blue diamond. Blue diamond is a coarse diamond. You have white, yellow, black. No, white, yellow, blue, green, black. Right? This is a company called Intensive. They are one of the pioneers in making these kind of preparation kits. Right? It is only used for this. You cannot be using another. They have specialized in CAD/CAM preparations. Right? Those balls are not routinely available on the market. It is very expensive. Right? Bar of 3 numbers or 4 numbers cost about 8 to 12,000 rupees. You have to keep replenishing. They are very good in first 5 or 10 rounds. That's our cuttings. After that, they have to discard.
This shoulder, then what is
It's here, no?
Sure, part.
And one of the format case or format case almost they come out with specialized skills. Now they are more specialized into bonded restorations. So I will come for another occasion where I will show you bonded restorations, stable top restorations, cervical veneers, onlays, endocrowns, all that are specialized skills.
after finish line, next steps, finish line establishment.
Finish line. Now, this the concept of biomimetic dentistry recommends the use of these what do you call?
What is it?
Discs. Right. The discs are available in various bits. Right. I don't use the course or courses. When you use this disc, you have to flex the disc against it. That gives you the best use. Don't go for the smoothest one or finest one. You take the second or third blade. Different colors, different companies. I'm so used with this 3M soap. 3M soap. Soap. This is soap. So each and every company have their own flagship products. So I'm so used to 3M since it was available yesterday. I had to bring. Nevertheless, this is one of the best in department. All my PGs use this. They know how it is. Now, if you see open this, they have given a range of small gadgets. After discs, they are given some rubber bullets which are available in the form of cones, right? With different markings, white, yellow, red. So those rubber bullets are meant for inspiring the enamel bullet. So today when I do on the patient, I will be using discs and the rubber bullets. And this concept, what we call it as biomimetic dentistry. So there are areas where you cannot use a diamond point. It's very aggressive. So these are used at a very low speed in the range of 750 to 1000, 1250. In fact, the inventors recommend torque motors like how we use for endo work for this. It's under your control. Right?
So first finish line establishment. In the same way, while establishing position itself, we give the label reduction. And then
So it has to follow the contours of the tooth. You see, I will just give you an example. When you do a crown cut for a molar, you have to prepare the way the inclines are. You cannot chop it flat, ask the ceramist to give morphology. No. Only when it is shaped along the anatomy, he will be able to layer the porcelain accordingly and give you the nice finish. Similarly, here also, it has to go along the anatomy of the tooth. So ensuring that the ceramist has enough room to layer. There are many times between the last wax technique and the CAD mill, the veneers, right? Both can be done exceptionally beautifully. Don't think that CAD is everything. The best restorations are always handmade. The finer influences, ups and downs, no two surface is straight. It's ups and downs, right? Transverse grooves, right? Horizontal lines, all that can be created only with hand. So when a composite I'll try to do today, I don't know how much I'll be able to achieve because the reduction is for a veneer. But still, I'll try to do if there is any opalescence or so I have come with some different kinds of composites which are used for giving special effects. Right? Opalescence is blue in color. Right? So I have got some special effect composites which are used in small amounts. Right? You may have to invest if you want to, if anybody is planning to do a respiratory work, you have to be very open in spending large amounts of time. Everything is expensive. Everything is patented. Right? The fellow who has done research and patented, for example, all of you are aware of Payload matrix V3, right? It was a guy in New Zealand who has patented this. He sold this to Dent's player for a multi-crore business deal, right? Now it is expensive. How an iPhone can be less expensive? It is a patent product, so it will be expensive, right? So the story is only when you see good work, your perception changes. Only when you start investing in good quality gadgets, equipment, materials, and frequently updating yourselves, right? Then only perception. Right? All of us have to see, as I told you, we are not here to do research. Right? I am not trained to do research, but we can be a very good clinician student. Right? It all starts from college. It's this place where you can do all this work. You cannot experiment many things in your practice. Nobody will come to you doing an application, coming again and again for it. It's impractical. Right? Not possible. Research is research, but we can be very good clinicians. Right? That is very frequent. The recent DCNAs have come out with a lot of 2025. Just open up that, you will be stunned to see a variety of new kind of authors who have studied. Gone are the days, Gallup, Dural, Pascal, Magnet, so many, those they are all there, but newer people are entered, bringing about with lot of newer ideas.
latest DCNA.
Latest DCNA 2025, January, February, you have wonderful articles. Right? Design. This count bond and restitution. This also comes under bond and restitution. Any other questions?
So insize will reduction, sir.
That depends upon how much you want. Right? If the situation demands high level of aesthetics, then you can go up to 100. There is no point, yes, in some cases you have enamel thickness of 2 mm. But what I feel, more the enamel is retained, the better is the prognosis for that veneer. Right? Just because 2 mm is required, you need not sacrifice 1.57. You can go up to 1. But the ultra conservative concept is difficult. There are very few technicians who can deliver world-class restorations, pointing from 0.3, slightly 0.5 mid-facially. It's almost that. Now I will layer a composite and here and show you. You can measure and see to yourself how difficult it is to do this work by the ceramics.
Finish line is
At the Vijayava. Now, if you feel that the discoloration is extending beyond Vijayava, then you may have to put a retraction cord, extend the, but that can happen only in a patient who has a gummy smile. Otherwise, don't bother. You're inviting more problems once you cross the soft tissue. Once the periodontal attachment is invaded, then the problem starts. See what happens when a restoration is delivered, luted, bonded to the product surface. Right? The first thing, there is increase in cranial fluid because it is still a foreign material. Right? The increase in cranial fluid will slowly progress over a period of time. 10 years later, you realize some amount of gingival recession is coming. So in my presentation next time, I will show you a lot of cases. What happens after 7 years, 10 years, 12 years, when the patient has got an aggressive tooth brushing, and an incident which I wanted to share with you all is how much you are with this electric toothbrushes. Now, whomever I have described, they all came back and told me the technology is fine, but we are not able to use. Whenever I use, the pressure is more. I'm not able. It is like some devices and all are available for elders. Nobody has got the mindset or the energy to take up clean their own. That is why handling somebody after beyond 75, 80 is not easy. Now, last week I had a very interesting thing in my clinic. 77-year-old walked into my clinic, right? He is a big time guy. He wanted gingival veneers. I've been doing on those areas. It's a separate topic after that. He asked, I want my teeth to look good. Why not? So you have a specialized shade guide for that from IPS Trust. Beautiful shade guide, and you have to be very careful. The patient is on warfarin sodium, patient is name it or blood thinners. I have to be extremely careful. So as I told you, one should have a very strong work discipline, fine working hands, and a passion for this. Then it becomes a reality. One cannot be clumsy in handling soft tissues. Don't think that everything, only when your base of soft tissue gives good integration, then it is fine. When you bond a veneer, it has to merge into the surroundings. Right? It should be difficult for anybody to see that a restoration is emerging out. That is the way you have to do it. Maybe we will try to do this today in the patient. What is time?
10:45.
Okay. Maybe.
The preparation change according to the materials to be used.
Now material today available. Yeah. Now if economics is a problem, there is an equally good material, indirect composites. It can deliver beautiful results. Right? Now, what is the difference between direct and indirect? Indirect composites are free from polarization shrinkage. Right? They are very well manufactured accordingly so that all these problems which you encounter with direct restorations no longer exist. And it is all done. Just show me that cat block. I have something for you today. Yes, I told you that there is nothing called no prep veneers, right? Where will the veneer go and stop? Give me blocks, no? 2 boxes I got. Sealer. No, it's there inside. Give it. No prep veneers, I don't believe. Right? Yes. It looks like alpine coffees. Please do not miss this. See, lost wax techniques has this kind of ingots. No box of that. This is lost wax technique, IPS ingots. Lost wax technique. Yes, this is the material. Now, what happens? The biggest advantage of it is that only. The biggest advantage of lost wax technique is simple laws of casting. All of us know that William H. Taggart introduced lost wax technique. Why it is still favored today and why it has become a big hit worldwide? Simplicity, right? Preparation is over. Make the impression over the cast, make a die, wax up, then put it in the burnout furnace. Wax gets melted. You have an empty mold. You take this ingot of the selected shape. You do in the pressing procedure. Beautiful restoration comes. This is everybody does this. This is less expensive. Now you have. Let them see. One more is there. I think somebody is taking. Nice. Now this is a very world-renowned company, Whelan, right? Only thing we don't have a technician, otherwise we have a full setup CAD cams here. Now these are called as blue blocks. This is how for a CAD machine. Blue blocks. Lithium metasilicate. Once it crystallizes, it becomes lithium disilicate.
It's a blue color.
This is it is in the best pre-crystallized state. It is easy. Okay? Milling பண்ணி இத வச்சு உள்ள வச்சிட்டாக்க இதுல இருந்து மில் பண்ணி அது lithium disilicate that is lost wax technique. Ingot put. When I pressable ceramic. You have a specialized furnace for that. Not every furnace is designed. This IPS, the concept of that is lithium disilicate was introduced by lithium in Iowa in 1992. Then different versions came. Then the best finished product was introduced in 2005. After that, it is only the changes, multicolored blanks, right? And better handling property, better coloration. They brought in bleach shades, right? A highly translucent ingots. All that are now the last 10 years. If you are planning to shell out more money, you can ask for a CAD. CAD is very expensive. Single restoration cost is 1,000. Whereas this, it starts anywhere from 1,500 and goes up to 2,000. Now, investment in a CAD machine is very expensive. The lab requires about 2 crores of equipment. And you need a very high qualified ceramist. You don't call a technician. The ceramist who can handle it. Okay.
Same sir for CAD/CAM and the
No, both can be done. Both are with good results. Right? Both are the same strength. Only the processing method is different. The only thing if you want to go for a CAD/CAM, you have to have a scanner, right? A Cerac Prime Scan, which is the best in the world, right? I think I don't know who came to my department. We had a program, and they are specialized that once you do the scanning, designing is over, you have a small milling chamber next to you. By the time the patient finishes his coffee, your restoration is ready. No other company has a system like that, right? It was costing 1 crore 20 lakhs. Now it has come down to 75 lakhs, right? You have to pay for the technology. Restoration is delivered on a single day. What more you want? No need of temporaries. No need of making the patient come many appointments, right? Everything is precise. Patient can watch milling going on. And by the time he finishes reading the book, your restoration is ready. How does you hear? But you have to pay for the technology. Okay. Shade selection. Shade selection, yes. Now, for you it may look blue, for me it may look green. It's very difficult. It is an art where you have to develop your skills. Otherwise it becomes hard. Now there are different shade guides. I forgot to bring spectrophotometer. We have. You have. Very good. I have everything in working on. I don't like anything being under repair. I don't like. Very reliable. 1.4 lakhs is the cost you have to pay for a spectrophotometer. Right? Vita. Now what I do, the small clinical tips which I like to share, I don't do anything in the preparation at all. The first appointment, as soon as the patient walks in, the teeth are moist. You don't ask the patient to wash so that it becomes dry. When it becomes dry, it takes 18 to 24 minutes. It's a scientific time to replenish the lost water. So what I do, the very first I do, there is one approach. Still you are not familiar, take some old composite. To the patient it is an inexpensive preview. The patient can immediately see a composite mock-up done readily before the patient feels very happy that this is how it is going to be the future restoration. Right? The best thing, you have a composite, all the composites are matching beta sheets. Right? If you have any doubt, because the shake gate, the drawback is it is an entire thickness. Whereas you are working on 0.5 to 0.7 like that. Even when you want to do a crown, after the crown preparation is over, you have to have certain thickness of tooth material to support the crown. But it is still 4 to 4.5 mm of good tooth structure. Otherwise the tooth will break. Right? Your restoration cannot exceed maximum of 2 mm. But 2 mm you can achieve only in upper anteriors. Very rarely in posteriors. 1.5 to 1.75 is my experience. Yes, there are some youngsters who have a full height of a tooth with minimal adhesion. Such cases you can go for it. But very rarely you will be able to achieve 2 mm reduction. 2 mm reduction is what is recommended for all these glass ceramics. But 1.5 to 1.75 is still fine. You can achieve. So do a nice composite mock-up with different shades. Take a photograph. Right? It has to be a part of your daily routine. Documentation, taking photograph, sharing it with patients. Right? When you see, within 10 seconds your eye gets fatigue. Right? Then ask the patient to lift all the lipstick. Do not wear all any flashy clothes. Right? Now, many things given are not practical. We cannot have that kind of setup in a place like India. But with the existing setup, it is reasonable. You can get good results based on simple measures. Do a nice composite thing. Today we'll do and show you. I will do and show you a composite mock-up. Right? Right? It just takes 5 minutes. Right? With your glove finger, take a composite, nicely implement, roll it on your finger, glove finger, the finger with gloves gives some warmth to the composite, so it becomes pliable. The cut streaks and all are gone. Roll it, just place it with your fingers, 5 minutes it is cure it and so without any etching or burn.
In this preparation, the incisor reductions.
I will run too little so that you get that 1 mm next week. I will do.
Digital mock-up is better or?
Yes. No. Again, it is driven by marketing strategies. There are a lot of talk on digital smile design. But what did I tell you? The basic procedure is the same. So companies have to make more money. Finally, you have to take a cast, make an impression, pour a cast, do a wax up, then those things are transferred digitally. Then you call it as business. Many a times it may look good on a computer, right? In reality, it's very difficult to achieve. Out of 10 cases, if you achieve with 1 or 2 cases digital smile design, it is something. I don't go into that area because all these things can be done within your program. There is no need to invest money on a software because of the 5 lakhs, expressive equipment, a simple measures of taking a cast, making a cast, ask the technician to do a wax up, then make a temporary acrylic, this acrylic temporary, put it in the patient, that is the blueprint. What more you want? Again, veneers can be only indicated for minor actions, not for wide space closure. Orthodontics will be first choice. So any doubts you can please ask. Yeah, you can do for lower teeth. See, the problem with lower is they are very small. There are patients who have big lower anteriors, right? These lower teeth are triangular in shape, if you see, right? And a very small group, right? Probably a few cases I have done. I'm not. Usually the lower teeth are closed by the lips. You don't get to do that. But there are cases where the indications were 6 to 6, 6 to 6. Again, with ideal overbite over time. So the best patient to work will be age group 30 to 40. Till 24 is young. Post-mandibular growth happens. This is what we have realized often. We say for a male it is 18, for a female it is 16. Sometime back when I saw a patient years ago, he was different. 2 years later, I felt this post-mandibular growth has made him look very different. So till 20 years, I don't touch. If you want to do direct composites, right? Direct composites are an indicator for small to medium sized defects. Other than facial, like what we are going to do today, other than composites, I do a lot of work, but I'm not a great fan of composites because very well done composites require frequent refurbishments. Frequent refurbishments, right? All these are done in controlled conditions abroad. Here we, in our local diet, last month I have done painstakingly a few class months. Within a week's time, the patient came feeling the restorations yellow. We add lot of turmeric in our diet, right? It doing everything. We only have to tell we have this system, but it doesn't work. Finally, I have started to do occlusal veneers. Right? Occlusal veneers is also a very nice option provided. You don't touch the contact point. And many times you get to do extensive class 1 restorations. Composites will fail because of their inherent resinous nature. Right? Wearing away of composites happen very well. There is a recent article in the Journal of Advanced Dentistry, right? 2022. Very well done where they have followed up about 2000 restorations, right? Meticulously by having a card. What is that? These are the things you have to follow when you do a restoration review. He says, which I also agree with them about, 2 years, 2 months is the time a nicely done composite lasts. After that it fails. And so what I do, I always layer it with a glass enamel. Right? It is safe, chemical adhesion. Wonderful material which will always remain in dentistry forever. Will never go off from the shelves. Right? One layer, 1 mm of nice traditional glass enamel. Fluoride recharge is very good. Chemical adhesion. Or you have to condition the glass after the food is prepared. You will have affected dentin here and there. You all know that bonding affected dentin is lousy, unpredictable. Right? A layer of glass enamel does that. Even if the composite gets dislodged, broken, it is the glass enamel which protects them. I believe in that. I have done countless restorations.
Like sample
Just it's a layer of GIS, right? In a flowable consistency where it requires, yes, everything has to be done under our sense. Yes. So what I do, the glass enamel itself is like dentin shapes. There are 4 colors available: yellow brown, pale yellow, cervical white, cervical grey, and translucent. 4 glass enamel shades are available. So I prefer pale yellow and yellow brown. Right? It is like mimicking dentin shape. It is matched according to dentin shape. See, when a glass enamel breaks, it is only a support. Whereas a composite, it is always glass enamel are the materials of choice for efficient or durable bond. It will stay there if proper precautions are taken. All right.
While bonding multiple values, what's the order of bonding?
Yes, interesting question. So many feel it is left to the individual. Some feel the centrals are the most dominant, high value teeth. Right? They should not go wrong with it. So some do this first and then move on quarter course. Some who are very well experienced start from the last tooth and come towards the front.
So it's like both central bond.
Yes.
So what were the interproximal?
Yes, it's very difficult. Once you start, you regret that why you have taken up this particular exercise of doing it. It is there, it is called as highly technique sensitive after the treatment. So your entire treatment becomes a success. The first part is your grip. Second part is efficient bonding. Right? You have to wear a loops, you have to have a good isolation. It is not possible to every time isolate under the bed. Right? Now, there are times we also make mistakes. Not that I don't make mistakes. I have a mindset to accept my mistakes. Right? Little more pressure on the that's enough. Whole day is gone. You cannot compensate for that. You may use viscostat to stop. All that is next. But one trauma inflicted is enough to affect your. It may look, everything will be fine at the trial stage, but during bonding, your glove fingers, these are all my personal experience. When you use the glove to handle veneers, the veneers are slipping down. The glove powder is brittle, right? You have special devices to carry veneers, right? I'm sure all of you are very familiar with the company called Clinic. Yeah. Who is willing to pay 8,000 for an implant carrier? Implant carrier. Right? It costs about 8,000. Cost keeps escalating. You have collected 60,000-70,000 for your first case. You will realize you have already spent 60,000 for everything. There is nothing left with you. Right? Looping cement. We call it as light curing cement. We don't call it as DOC. A light curing cement is very expensive. You have available in 6 colors. Different companies. The single syringe costs about 4,800. Right? Just 2 cc's of material is all available. By the time it is imported and reaches in the 6 months, you have only 1 year or 2 months. They also have to make a lot of money. If they give long shelf life, you will not buy. Right? So, when the second part, I will spend more time on discussion than on presentation. How to go about doing this bonding of stress. I have a lot of nightmares and my stress levels are very high when I sit and do 4 to 6. Right? The entire evening is for that. Maybe a good secret tracker, opera gate only, no, but secret tracker. It's still nice.
Opera dams.
Opera dam, yes.
Tell me about that.
What did your friend tell about this? Since you're asking me this. That's up to you. If you are comfortable with doing the first 2 centers, or starting from canine and coming towards center, that's your choice. There is no hard and fast rules. As long as you are able to do an effective bonding, it's fine. Right?
Breaks.
There are specialized bands which have got it today. We'll see whether it is possible.
Break for snacks.
We'll just get back in 10 minutes and there are a lot of work to do.
Take care.
Oh, yes. Local Balaji. Oh, local Biju. Balaji. So, one funny concept, I know. We'll be doing one more preparation.
Stabilize it.
Tray mari kudiya ma'am take it.
Low touch. Low touch. சரி இதே ஃபோன் பண்ணி சொல்லிட்டு ஓகே சமோசா சாப்பிட்டுங்க கொஞ்சம்
ப்ரோக்ராம் வந்துருக்கு ப்ரோக்ராம்
I'm trying to fix a rubber dam so that கொஞ்சம் Can it be like this, sir? So that directly.
But again, very small area. Otherwise, avoid not immediate. You know for sure that you are improving. Actually, what gets to Papa, அப்போ என்ன பண்ணுவோம் கொஞ்சம் இப்போ வந்து இப்போ லெட்டர்ஸ் எல்லாம் கொடுத்துருக்கு நிறைய அட்மிஷன் அதெல்லாம் பண்ணுறது ஆல்மோஸ்ட்
Not indicated without doing anything. Apply application
in a loop send a magnet.
But if lot of groups like microscope like alignment someday it doesn't they observe what's a significant improvement in the கான்செப்ட் ஆஃப் மைக்ரோஸ்கோப்லாம் கொஞ்சம் நாள் போயிருந்தா மைக்ரோஸ்கோப்லேயே பண்ணுற மாதிரி இது வந்து ப்ராக்டிக்கல் பண்ண
Vivek Babu.
Since I switched over to
அதிகமாக இருக்காது பிஸ்னஸ் அதிகமாக இருக்கா
ரொம்ப தூரம் அப்படின்னு பார்த்தா
ஓ கிட்ட போ
பண்ணிடலாம் சார் நீங்கள் கால் பண்ணுறது
one drawback is not using medication. You are all wearing spectacles. All of it is I don't know. I stopped working these are all occupational hazards. Almost every so I have got some nice very nice bits available marketed by Densply. So every company have their own flagship products. Right? You need to find fault with this. I love this product. It comes in different shapes. So the best part is the company gave only I was under the impression that it was policy in place. Diamond policy, right? This is the only company which gives two cylinders, regular and smooth, right? So when you apply this and run a special buff provided by this, right? Lifelike aesthetics achieved. I love this product. It's a wonderful product. So the kit is available in all these forms. It does not cost much like here. It costs about 6,000 or 5,000, right? And if there's all these products, whatever I told, has to be single hand. You cannot ask many people to handle, right? So very precious and because small mistake, it's gone. which I bought it in 93, right? It still looks new. Those days perfume were available only by foreign companies made in Switzerland, original stainless steel. Right? I'm sure it is older than you. Right? It still looks fine because I have made it. So maintenance also is very, very important. So I am using this today. I have given you some small compules. Material is available in the form of compules. Right? And the best part is this company, the compules are designed where it has a very small nozzle where you can syringe material with this. You don't have any wastage. I don't think any other company has come out with this design. Beautiful design. I'll show you. You have three different kinds of finishes. You have a cone, you have inverted cone, and you have a disc. It's to use on any tooth surface, either a molar or a mandibular. Okay? So you have a nice way of doing it. Right? So restoring is first part, finishing and polishing is second. A few lines over these areas, restorative. I believe in using multi-product tungsten cameras. Right? That gives the best finish. Then you use this. It takes your next step. Right? So the multi-product carbides are kind of, if you open the book, right? One of the best books to read about all these mechanics of tooth preparation or cutting is simple. Right? It is the only book which gives a detailed description about each and every item. They say you start with diamonds. When you reach dentin, you switch over to carbides. Carbides are kind of different. It's not that diamonds are harsher to cut, hard done. So the book recommends use of carbides to finish it. The same mechanism. Design is a very soft. What a nice achievement you have made. Prepare whatever nice build-up you have achieved should not be lost with an aggressive work. That's why the manufacturer or even the book was the final part. It has to be finished by multiple. Just a quality and last property. Again, it comes up with very good. Each and every piece of work comes up about 18 minutes. Right? And with gloves. It has to be clean. You cannot ask your assistant to do. He will do it all. Right? Sir has asked me to do a preparation now. I will finish the preparation. 12 minutes time. If I am exceeding, I will stop. Okay? Now, you have to fix up. See, we are all called as professionals. Why is that? When you give a time of 50 minutes, you should finish the work by 45 minutes. You should have the remaining 3 minutes time for removing all that before the next patient walks. So time is very crucial. In a busy practice, every 1 hour I have a patient walking. I will tell the patient that I will finish by such and such time. I will finish. Right? Even a normal cloth also is fine. அது அங்கே வேணும். ஒரு க்ரீன் கிளாத் ஏதாவது வேணுமா? க்ரீன் கிளாத் சொல்கிறேன். இங்கே இருக்குமா? Okay, let's start. Now, for a beginner, without touching the mixed tooth, right? It's very important. Once a small leak is created, it's a permanent problem to the patient. It's like when you do a crown prep, you have to take the required precautions of not touching the next tooth. It's a big mistake when you touch the next tooth, and the patient will have contact problems forever. A small open contact can lead to, the only option is to do a restoration because of your negligence, not following protocol. So for your sake, I'll just keep one nice, whatever we do here is totally different from what we do on a patient, right? Check. It's not fine. Let them see when I'm doing. That itself they will know. Then I'll explain. Okay, start.
First step என்ன சொல்லிடுறேன்.
First step is just
Finishing.
Starting a new preparation with finish line.
Okay. First step is starting the new preparation with a finish line. Hello. Okay.
I'll start.
Please start.
Just reduce the water flow. No? Yes. More.
So checking the water flow. He feels the water flow should be adequate to get a washed feel and to make sure he's staying in enamel rather than exposing dentin.
Yeah, reduce. Okay, we'll manage. That's all. It's okay.
Dr. Vijay in action.
Yeah. కొంచెం జాస్తి పడలా. Yeah, enough. Srimadi, take care, water is down, dripping down. இங்கே மட்டும் கீழே பார்த்துக்கணும். க்ளோதிங் பார்த்துக்கோ.
The name of the shampoo.
Medium depth shampoo.
Medium grit chamfer work. So he has created the cervical finish line. Now he is doing the preparation medially and distally to create another finish line.
சுத்தமாக வரல, வாட்டர் இல்லையா? பூஸ்டர்ல
Any questions you can ask right now, I'll ask him.
In this we can't limit the depth also.
you want, I'll show you the depth cutters in lateral incisor to show how it can be used.
Because in that
I'll show you now. கொஞ்சம் நடிச்சு கொஞ்சம் பண்ணல இல்லை
See how the bug is
See,
angulated.
there is another approach from cervical. This is how you control. You don't do this. Whereas from cervical, you know, and towards occlusal. Give me the round back. So what I do, I reflect the light onto my mouth mirror, onto the cutting side, and indirect vision. You have to practice the habit of doing in dentistry indirect vision, right? 1 or 2 patients will get away without falling. 2-3 days later, you start getting neck, backaches, and that becomes your occupational hazard. So, going to do incision overlap.
stain happens.
You see this specialized diamond where it point where it has got diamond only at the tip, right? Your area of contact with this diamond is only at first 1 or 2 mm. So that's how these are designed, exclusive for veneers. If you still want to refine your prep, you can see this chamfer diamond. Red is medium coarse. You see the diamond point has only a chamfer head. I can use this and show you how to refine the finish line. Keep this next time. You can afford to sink your burr because incisally its enamel is very thick. At the cost of enamel you can. Suppose if the patient has high aesthetic demands, it's the incisal porcelain which is going to give you the chameleon lifelike effect. The handpiece has to be used in a single pendulum motion. 2 to 4 ounce is the pressure exerted from your finger. I prefer a handpiece which has a torque induced or torque controlled. You have a standard turbine and torque handpieces. Standard handpieces run at a speed of 4 lakh revolutions. It runs at a high speed, but the cutting efficiency is not great like a torque handpiece. An air turbine with a torque runs at a speed of 3,50,000. Right? What it takes half an hour with a standard, you can finish it in 5 to 7 minutes when you use a torque handpiece. So how do you identify a torque head is bigger than a standard head? It is expensive, but your work is greatly simplified. Your strain on your fingers is greatly reduced. You have a great working control as it finishes very fast. Give the other. I'll refine the finish line so that it is more pronounced. Chamfer gives the best finish line as it minimizes the stresses. Most conservative, easy to be reproduced. Don't run the handpiece to and fro. It has to be in only one direction so that you have a very good control of the working area. Right? Now I'll switch over to discs. You see how I flex? Discs are meant for flexing while working. That gives great finish. I come back to the 1 o'clock position. This particular company works in only one direction, whereas 3M Soflex discs can be removed and put it the other way. The other reason for using these kind of devices, you can just finish the contact point of the next tooth. I'll remove this matrix band. It is important to plane the surface of next two teeth so that it's smooth. Now in this case, you see the finish line has not gone to the contact area. Now I will extend this this finish line proximally here. Probe will come. You have a probe here, or a probe or any sharp instrument, even a diamond will do. Now you see here, unlike this central, this is only here. So the contact point or the finish line has to be taken to the hidden area just before the beginning of the proximal contact. So I'll just extend my preparation little bit in between or proximally. So again I'll put a matrix band. There is one more diamond small. This is very thick. You know the chamfer thicknesses are 1.2, 1.4, 1.6. You have to have the entire three sizes to suit the different thicknesses of central incisors, right? So in a busy practice, you cannot have one standard size and use and remove unwanted good tooth structure. That cannot happen. That is unacceptable. When you start preparing the way how to achieve ideal, so I keep the diamond at the center and divide the central incisor into two halves, keeping an imaginary line. I start finishing the first half, then I'll know how much tooth structure I have removed, then come to the remaining second half and merge it. So I know that I will be on the right track. Like how you are very familiar from this side to go on the other side. You can practice yourself by coming to this side so that you know for sure, you make the patient turn to the other side so that you have full view of your proximal side. So you don't make any mistakes. This is how most of the oral surgeons do. When they want to remove 3/8, they come to that side, ask the patient to turn so that they have a full access. Similarly, those things can all be incorporated in your work style. Okay? I'll just finish it with discs, that it is over. Always support your handpiece like this. When you are working on these areas, you are possible to make an injury or remove more. So take a finger support like this on the next tooth, right? So that you have a very good control over your working. Only on these situations I come before the patient or the side of the patient. I'll show you how to use bonded abrasives to give a nice finish. It's a wonderful piece of device. I always approach from cervical to occlusal surface. Look at the finish, it leaves. As usual, all sharp margins are rounded. When you follow the anatomy of the tooth, the technician is able to give you the same way. Another trick to get it right and patient not to feel other words. Before I start, I make an impression for a cast, send him, this is the pre-operative cast, send him photographs, let him have a look, right? We all know upper anteriors are in the form of an arch, posteriors are in a straight line, right? So you have to do your prep according to the arch, right? So he will get back, if it is a male, what do you want to do? If it is a female, make small notes, attach it, send it, right? Nothing wrong in taking a scan, sending to the lab, so that let him go through all that. And presently many technicians are asking, keep shade tabs, different shade tabs according to the value. Now your shade tabs are arranged according to the value, right? A, B, C, D, right? And yesterday I came across another company, Omnichroma. I think you might have heard, multiple shades in one composite. For the first time they told me A5 is available. I never heard of A5. So I am inquisitive to know what is A5. A3, very few patients will have A3.5 in elderly. So veneers are not contraindicated in elders. The challenge with elders, attrition would have taken place over a period of time. Very little enamel is there. You have to preserve that enamel. Once enamel is lost, the next chromatic dentin gets exposed and the tooth looks dark and the translucency parameter increases. It's very difficult to restore an elderly patient with veneers. with the true colors. It's difficult, not impossible. Experienced ceramists will be able to use the fine powders to give this kind of effects. Right? Now you can have a look. Now, the best part is I have prepared 2 teeth. Both are good, but both are different. Right? That's how it is. Now, if you do 10 preps, all will be according to the book, and all will be different. It's very difficult to have the same kind of. The incisor which I worked on had a different kind of enamel compared to other one. The one which I started first had a nice quality of enamel, so that it looks better than this. These things come across because the thickness of enamel varies. Right? In some areas, if the tooth is slightly tilted, you may have to remove a little more. Right? Compromising enamel. Right? So the technician will get back to tell you that the ceramic in that area is thinner. So when you bond, do not exert pressure. You know, they are all very fragile. They are delivered to the clinician like how jewelry is delivered, right? In a specialized, small, very well crafted boxes. Even if it is thrown from 5th floor, nothing happens. That is the way the veneers are all delivered. One careful mishandle from your side, it will fracture. But once it is bonded to the enamel, you have to only cut and remove. I have done a lot of cases. I have an option of doing on 3 patients in the last 15 or 17 years. Redoing the same veneers. It was an extra challenge for me. Preserving the same quantity of enamel. Now, literature is sparse how to remove a dying veneer. The most common problem is gingival recession. These 2 patients had bruxing habit, which they didn't tell me, which I could not in my initial days. Right? We matured over a period of time. When I compare myself 15 years ago, I'm much better today, and learning is a continuous process. I cannot say I'm an expert, but I can deliver a good piece of work. Right? So I had the opportunity of redoing those cases, right, which was very challenging. Removing the specialized, like ensuring that the same enamel, the cement. Then I realized the strength of the veneer is so much when it is bonded. It's not easy. A combination of techniques like how we remove a fractured instrument from the root canal. You cannot say this technique is best. You have to use a combination. And very little literature is available on all these areas. And redoing on those cases is a big challenge. Right? Have a look. I'll just refine that. Three-way syringe. No, I have this habit of using 3-way syringe with water with. It cleans up very well. You see this? You need not. So once the patient gets up, he wants to say spit, everything is gone. You never allow him to do that. A lot of time is wasted. Your position changes. Everything becomes different, right? These are small things, clinical tips where you can do a great nice piece of work. There is another burr here. I like this burr. You see it is big, flame shaped, right? There is one more given in the kit. You have a red and an yellow. Right? In my opinion, both work very well. So I will use this to just reshape some of the areas which I have not done before with others. Madam wanted depth cutters to be used. I will use and show you. I will only require 5 minutes, right? I reduce the other veneer also. If you notice, I use the thickest portion of the diamond. Again, I'll go back to the discs. I wanted more material to be kept at the incisal area, so your reduction will have to be more. I will show our depth cutters how to use. I will work on this lateral incisor. Huh? Over a period of time, anybody will develop their own way of doing it. Right? So it's very difficult to answer your question. Yes. Now this we will see how good it comes. I'm also doing after a long time, but I have started with this. Okay. Now, if you see this, these diamonds, you can never place the entire thing like this, right? Either you have to do, right, the one which is here, thickness is less. That is because you are working on cervical area. Cervical enamel is very thin, so the diamond is very less, right? Even in a long tooth, it's very difficult to orient the entire length of the diamond because it's always a two-plane diamond. Tooth surface is not straight, ups and downs. You have to follow the contours of the tooth. Now, even after having correct shape, if the shape is not fine, the patient will notice and tell it is not looking nice. So you have to prepare right from the beginning, keeping in mind that the same shape of central has to be finely reproduced in the ceramic. Okay? Chamfer. It's a very aggressive diamond. I'm not very comfortable. If nothing is there, I have no issues. But if some other diamond is there, my preference will be only that, not this. Okay. at an angulation of 30 degrees. In this lateral incisor, I am able to bring the contact point almost near to the proximal. This one tooth I will prepare up to incisal without involving incisal. There are situations where you come across, why do you destroy that nice beautiful contours which natural tooth has? There are situations where you have to restrict, but it is the work of ceramist which is very difficult for him to finish incision without an overlap. So I come back, I start from the cervical, so I ask the patient to turn to this side so that I have a full view of all. Now, here is a problem. When you bring the diamond here, how to avoid this? That's a challenge because it's a natural enamel. Okay. Give me that flame shape. Now, this is a big flame shape. I'm going to use only the tip of that diamond. That finishes. Again, I will finish this next tooth. Now, here it is sharp. Done. போலாம் முடிச்சிடலாம் டக்கு முடிச்சிடலாம் பேஷண்ட் வெயிட் பண்ணுவோம் just have a look. I'll just do some prep on the patient's mouth. Most important, my teeth. Necessary? That is, if you want, I will address the little later after I finish the patient. Where all you can go wrong, how to become confident. Right? So when you go for lectures, nobody will tell you all these details. They will only show 3 posts. Nobody will show 10 years later, 15 years later.
See the type of acids.
Right? They simply tell that
See the type of acids.
but if you ask something, they ask to be honest. It may look very simple. It's very difficult. It takes years of, that is, if you do a case today, you have to continue doing this on a regular basis. Otherwise, you will lose track. It's like working under a microscope. You stop using it, you have to start again. Right? I told you, find working hands, artistic hand, a passion for your work. One need not be MBS to do this. Right? Some have got a lot of creativity. So those people and all will do very well in these